We now move on to the next talk, Self-Sustaining Community Eye Hospital by Dr. R.D. Ravindran.
Yeah.
Dr.
So good morning. Thanks for the opportunity to Dr. Partha and others, the AIOC Scientific Committee, to present this. We just heard from Dr. Tittial the prevalence of blindness in India. So, but if you see this as numbers, not as percentage, we have close to about 47 lakh people who are blind, who have vision less than the presenting visual acuity is less than 3/60. Those who have severe visual impairment, that is between 3/60 to less than 6/60, is about another 46 lakhs. Those who have moderate visual impairment is like 2.45 crores. And now the WHO has redefined the threshold for intervention, which is early visual impairment. So anybody less than the vision of less than 6/12, I think whether it's a cataract or not refractive error, it is mandatory to correct them. So all this adds up to about close to 7.3 crore people who need some kind of intervention. This is beyond even routine screening of glaucoma, diabetic retinopathy, managing all of that. So who may not come under this category. So the problem is huge. So as he mentioned, the government alone won't be able to take care of all these patients. We also need the patients who have to be cared by other non-governmental organizations. The one thing is only 40% of this population can afford to pay for the care. Of the 7.3 crore patients, only 40% can pay for it. Nearly 60% won't be able to pay for it. And not only that, among this 50%, 60%, nearly about 50% or 30% of the population cannot even reach a facility. Who we have to reach them either through a primary vision care centers or through a community outreach camps becomes very, very important. So this is where the role of community eye hospitals is really needed, who can create the awareness, create the access, and also make it affordable for the population. And again, why these organizations have to be self-sustaining? Because the cost of the equipment and other resources, there are also pressures on accreditation, and there is also a reducing support for recurring expenses from the international NGOs. And any hospital requires a profit or a surplus if they really have to upgrade themselves or remain sustainable in the long term. So when you talk about self-sustaining, it is both financial sustainability or the viability, and also ensuring the availability of the human resources. Both are equally important. I'll touch upon both. When you look at the financial viability, it is about how do we meet the expected financial needs from the sources on which we have full control. We may be getting maybe some kind of philanthropic support from outside or from the government as a grant in aid, but we need to get revenue which will be more than the cost of the eye care services we deliver in the organization. So here both maximizing the revenue becomes important and minimizing the cost becomes important. When you're maximizing the revenue, it's also at the same time we also need to take care of social obligations and take care of the market dynamics, and we need to minimize the cost at the same time, not compromising on the patient satisfaction or the quality. Both are equally important. Just looking at these maximizing revenue and the minimizing cost actually go together. They cannot be seen separately. But now there are three distinct things which really impact the revenue. One is the volume, other one is a service mix, and the third part is the how do you close the loop. The volume is really important for a community hospital. So one, we need to make sure that we are accessible to all the sections of the community. So any community hospital should have a free and a paying section, should have services available from morning to evening, and ensuring surgery for the patients on the same day. Because if you're going to ask the patient to come back again, you're going to make the access difficult and you're going to increase the cost for the patient. And all these are important to lower the threshold. And again, having the primary eye care centers, Dr. Tittial showed that government is looking at 40,000 plus centers where they have about 4,000 or 5,000 centers. These vision centers really create better access for the patient and also make it affordable, because only 10% of the patients who are seen in this rural vision centers have to come to the hospital. So that much, the cost is lowered. And just sharing this data from our Teni hospitals, where we have about 8 vision centers, wherein each the year we see little over 100,000 patients, and about 3,000 patients are referred for surgery. And again, those who cannot be reached either through the hospital or the vision center, you need the eye cams. And Dr. Titial also talked about the various forms in which the cams we need to conduct. And this is an interesting slide. Now, I'm just showing the 100% of the patients and their breakup. What you see on the top, all yellow is all the free patients, and the bottom, which is the blue, is all our paying patients. So in the year sometime in the 1990, as we introduced intraocular lenses only for the paying patients, so then slowly the percentage of the paying patients went up to even 35 to 40%. But the minute the government started subsidizing the services in the camp, they said no, they'll even pay for the IOL surgery. Then it completely dropped, even went below 20% at some point of time. But as the economy became better, the quality of life became better in the country, slowly the paying volume also increased. Today, we have about 40% of the patients. This also reflects in a way the economy of the people. So here you see this is in 1985, nearly 90% of the patients, their annual income was less than a lakh. But today that number has come down to that percentage has come down to about 22%. As a result, we have a lot more patients who can pay for the services. And so there is a group which can pay above cost, but the large population can only pay for the subsidized things. And again, when we looked at what the community can pay, each hospital we looked at what is the average revenue per surgery. One of our hospital in Theni, the average surgery was about less than about around 5,000 rupees compared to the other hospitals. When we looked at it, we found that our hospital at Theni, being a rural hospital, was not advising phacoemulsification surgery for these patients. So when we changed that, the uptake of the surgery, from the phaco surgeries went from for 40% to 59% of the total cataracts operated. Interestingly, the total volume also increased over a period of time. Yeah. So, and again, this is one other instance where a hospital where the number of patients they were seeing close to about 4,000 plus patients, only 1,000 were getting operated, 3,000 were not getting operated. The second year, similar. They have advised a surgery for 3,000 patients, but they are operating only 1,000. So as a result, both years together, they have not operated on 5,000 patients. So if you put that average of 10,000 per surgery, there is a lost opportunity here. So how do you closing the loop through counseling and other mechanism becomes very, very important. And again, the service mix. If you see, this is an example where the outpatient number went by 3%, but the cataract surgery volume went up by 13%. These total surgeries went by 15%, but the income went by 30%. The reason the number of cataract surgery went up higher, maybe because of a better counseling. And there is also a patients moving towards taking premium lenses and high priced packages. All of that service also mix also can impact on the revenue. So I'll just skip. There are two things which will drive the cost. One is your efficiency and the scale. We are talking about your fixed cost and the variable cost. I'll just skip these things. I'll go to and again, paying attention to quality becomes very important. The good quality will reduce the cost. A good communication also enhances the willingness to pay. And again, when you do like a community work, local community takes care of certain amount of the expenses. The hospital takes certain amount of the expenses, and the government, through the grant in aid, we are also able to cover. And then overall, this again makes the whole approach, the community-oriented approach, also makes it easier. I'll just go to the one last slide, which is on the marginal cost, and I've taken the example of one of our hospital in Theni, where we do close to about 10,000 surgeries. So here, look at it. This is like old data. The year 2008, they did about not 2000. There's 2008 surgeries. There's a fixed cost is about 94 lakhs, and the variable cost is about 25 lakhs. Overall cost is about 1.19 crores. The unit cost per surgery is about 5,938. And whereas the fee which we charge, average was about 7,000 plus rupees. As a result, we were able to create a surplus of about 33 lakhs from this patient. So these paying patients were able to take care of all the fixed cost also. And when you are able to cover all the fixed costs through your paying patients, the rest of the patients who are subsidized or come from the camp, so whatever cost they are paying or whatever cost you get as reimbursement from the grant in aid, you are able to generate a marginal surplus. We have done about close to about 5,000, you can say about 5,500 surgeries. We were able to even there earn about 15 lakh rupees from that. So you were, because all your fixed cost is taken care by the paying patients, so you are able to still generate a revenue. It's all again coming back to the volume and the scale, which is important for a community-based hospital. Again, ensuring human resources, training, all of that is important. And also monitoring information system is really equally important to ensure that you build it. And again, it's all about a purpose-driven leadership. The building the organization DNA
Can you
is
wrap up,
very
please?
important. Yeah, is the last line. And having an inclusive design, a culture of cost consciousness, and evidence-driven organization is all that important.